Hello there. This lecture will be on the topic of mood disorders. We will first be talking about mood and altered mood in general, and the focus on a couple of exemplars. The first exemplar is major depressive disorder, or MDD. We will also discuss adjustment disorder with depressed mood, which is similar to MDD, but we will highlight some differences of that disorder. We will also talk about bipolar disorders. Mood disorders fall under the concept of coping and adaptation, which is part of the psychosocial domain. Here are the objectives for this lecture, and I will let you read those on your own. Notice that in addition to applying the nursing process to the exemplars we will discuss, I want you to be able to describe the collaborative interventions for MDD as well. It is typical for all of us to have a wide range of moods, either elevated or happy, or depressed, or cycling between these levels. So when is it considered abnormal? The answer is when the mood is not appropriate for the situation, when the mood or response is out of the proportion to the stimulus, or when moods shift dramatically or rapidly out of the proportion to external factors. These dysfunctions in mood become classified as disorders when it is pervasive, which means it affects day-to-day functioning and when it impacts most areas of life. Mood disorders affect nearly 10% of adults. The graph represents various types of mood fluctuation in several disorders. Notice the line that says euthymia. This is stable, reasonably positive mood, or what we think of as a baseline or normal mood. The red line represents someone who experiences periods of mania, which is abnormally elevated mood that affects functioning, euthymia, and also depression. There are some cultural considerations with mood and mood disorders. Culture plays a role in how moods are expressed in general. So for example, culture influences when people are expected to experience sadness, loneliness, joy, etc., in response to a situation. In Western culture, think for a moment what emotion is expected after having a baby. Typically, joy and happiness. That is why postpartum depression can be so difficult and isolating for many people who give birth, because they are not experiencing what culture expects from them at that time. Culture also determines how one should behave when experiencing certain feelings. For example, does your culture or the family you came from allow you to cry when you're sad? Or is it more acceptable to act angry? Somatization is the process by which psychological distress takes the form of a physical body sensation, and the degree of this can vary from culture to culture. We need to be careful to take cultural factors into account during assessment, but to avoid stereotyping patients or making assumptions because of their race, social class, gender, or ethnicity. This can prevent the development of the therapeutic relationship that is so important, particularly with psychiatric nursing. So what contributes to our mood? Factors that influence mood come internally from our brains and personalities. The limbic system in the brain is responsible for emotions and mood. If there is improper functioning of this area, alterations in mood may happen, as this has been seen on brain imaging studies. Some personality types predispose some to a more negative or more positive affect. So remember, affect is the mood that's visible to others, while mood is what the individual is feeling. Stress is an external factor that, when chronic, can affect internal factors such as brain functioning and hormone levels. Stress can also impact sleep and appetite, which are also factors for an altered mood. Supportive social interactions are connected with a more positive mood, and typically speaking, those with more perceived support tend to have lower risk of mood alterations. Mood also tends to be affected by the circadian rhythm of the day, with most commonly a lower mood in the mornings, peak in the afternoon, and then a gradual decline into the evening. As people grow into adulthood, mood tends to become more stable compared to adolescence, and older adults generally have more positive mood than younger adults. Finally, a medical illness that affects the brain or hormone levels can affect mood, as well as any chronic illness which may affect the quality of life and trigger depression or another mood alteration. An alteration in mood is when it is excessively elevated or depressed. Think of the graph with euthymia as a normal mood, mania is elevated, and depression is very low mood. In addition to this change in mood, we may be able to observe a change in affect. An individual may display poor coping responses, such as avoidance of facing stressors. An altered thought process may show up as poor memory or concentration, indecisiveness, or in a more severe case, paranoia or delusions. Changes in sleep can often accompany altered mood and are often a defining characteristic of the mood disorders. For example, when individuals have an elevated or manic mood, they may not sleep, and an individual with depression may sleep excessively. Somatization, as we have discussed, is when someone experiences physiologic distress in a physical response. Common examples in those with mood disorders may be fatigue, headache, and dizziness. An important point to remember is an altered mood becomes a problematic or a disorder when there are difficulties functioning safely and independently in daily life, such as maintaining home, fulfilling work or school obligations, proper nutrition, etc., etc. There are multiple mood disorders, and this is not an all-inclusive list, but this lecture will be focusing on some of the more commonly seen mood disorders: major depressive disorder, adjustment disorder with depressed mood, and bipolar disorders types 1 and 2. Physiology of major depressive disorder is unknown, but there are some brain changes that have been noted on imaging studies and various theories. The most commonly accepted theory until recently was the neurotransmitter theory, but there are also factors related to hormones, inflammation, and social or societal stressors. MDD is characterized by a change in several aspects of emotional state and functioning over a period of 14 days or longer. MDD may consist of a single episode, or there could be recurrent episodes at various points of life. An untreated episode of MDD can last for 6 months or longer. In some individuals, symptoms can last for years. The onset of first episode can be at any age, and the average age of onset is mid-20s. Women tend to be more affected than men and are about 2 to 3 times as likely to develop depression than men. MDD has a hereditary component where first-degree relatives of those with MDD are 2 to 4 times more likely to develop depression than the clinical manifestations of MDD will include a depressed mood most of the day, which patients may not describe as depressed. It may be described in terms of sadness, discouragement, hopelessness. Symptoms usually develop over a period of time, and individuals may experience anxiety and mild depression for days, weeks, or months before the onset of a major depressive episode. Diagnostic criteria require 5 or more of the symptoms listed to be present during same 2-week period, and symptoms need to not be induced by someone or be attributable to another disorder. Also, many of these symptoms can be reported by the patient or someone close to them. They may not experience every symptom on the slide, but these are commonly seen. The loss of interest is a loss of interest in activities they once enjoyed. There are some important lifespan considerations in terms of how depressive symptoms present. In children and adolescents, functional ability is usually assessed in the context of home, such as ability to complete chores, and school performance, like grades or following directions. There may be report of new problems with parents or teachers due to problem behaviors, and oftentimes depression is experienced and expressed as irritability in children and adults. This may be due to inability to qualify and express emotions at this developmental stage. Recall that depression is not an expected or normal part of aging, but older adults have some life events that increase the risk of its development. MDD can present in non-specific ways for older adults, such as with new onset memory problems, social withdrawal, sleep problems, appetite changes, and with delusions or hallucinations. Your nursing assessment will include assessing for symptoms of MDD as previously listed and discussed, as well as asking if the patient has difficulty completing simple tasks, such as daily care, hygiene. Observe for tearfulness. Be attentive to somatic complaints, commonly abdominal pain, headache, body aches, and note any withdrawal or social isolation. Assess for the patient's strengths and resilience factors, as this can be helpful in goal setting and interventions. Assess for comorbidities with MDD. Common comorbidities are autoimmune issues, cancer, metabolic abnormalities, endocrine issues, as this disease or the associated medications may be contributing to the symptoms. Always assess for safety concerns and complete a suicide assessment, which you will get in future lectures. In the hospital, a patient with suicidal thoughts must be placed on a suicide precautions. This will vary per agency policy, but generally will require a frequent, which is once a shift, nursing suicide assessment, documentation of risk level, details about the SI, and a treatment plan for reducing risk. There will be implications for transporting the patient off the unit if they need a procedure, such as a need for staff to accompany. And there will be adjustments to the physical environment to promote safety. Examples are breakaway shower rods, window locks, light fixtures shaped in a way where something such as a sheet could not be suspended, no accessible window shade cords. know that hanging is one of the most common means of suicide in the hospital. The patient will be placed on an observation level, which may also vary per agency. One-to-one means a staff member stays within 2 feet of patient at all times. Eye contact is when the patient is within the line of sight of a staff member at all times. And every 15-minute checks means they are to be checked on and activity documented every 15 minutes, which is routine at most agencies for all patients, regardless of suicidal ideation or not. There may be other restrictions, such as needed supervision while in the bathroom, and it is common for all patients, but identifying contraband requires inspecting patient belongings and removal of all prohibited items that could be used for self-harm. Examples are shown, but can you think of any additional items used every day that can be used for self-harm? Other common examples include shoelaces, belts, jewelry, pens, nail polish remover, sharp objects, glass products like the vases or glass on a picture frame, your matches, lighters, headphones or earbuds, medication brought from home, toiletry items such as dental floss, aerosol spray cans, or razors. As we move into the nursing process, I have a case study to help illustrate the points. Go ahead and take a few minutes to read the case study about Kate and think about what an appropriate nursing diagnosis may be for her. Remember that nursing model focuses on the patient's response to an illness. So while we may be giving medications to help with mood, our nursing interventions and diagnosis may have a focus on some of the symptoms associated with MDD and the depressed mood. Examples of nursing diagnosis that may apply to a patient with MDD include risk for self-directed violence, chronic low self-esteem, hopelessness, social isolation, and ineffective health maintenance. Any of these could be applied to Kate, but which of these would be our top priority? She's having some active suicidal ideation with some evidence of self-harm, which is our priority. What would the nurse's next action be after hearing Kate's SI? Obtain more assessment data to determine the level of risk. Goals and plans will correspond to the nursing diagnosis. There may be targeted at things like the patient remaining free from self-injury, the patient meeting functional needs such as completing hygiene or other activities of daily living, the patient participating in recreational activities of the unit. It is rare for a patient with MDD to desire or even to be willing to participate in unit activities and socialization. Remember, this is part of the symptomatology. A point of education may be explaining to the patient that feeling better will follow participation in these activities, so sometimes they need to participate before they feel like it. So it may be one of the rare cases that we don't put patients' preferences, such as preferring to stay in their room rather than eat lunch in the common area, before the needs related to their illness and treatment plan. The patient adhering to his or her treatment regimen is important as well because it is common for patients to stop treatment once their mood and energy levels improve. Interventions are going to help us meet our achievable and measurable goal. The therapeutic relationship is foundational to the interaction with patient and helps them to build trust and speak openly with us. The nurse can provide distraction if the patient is self-focused, which may include easy recreational activities and simple conversation with staff. We don't want the patient to remain focused on their hopeless feelings. Encourage activities, as I previously mentioned. Being active and taking part in activities promotes a more balanced feeling state. Recognize the patient's accomplishments, but avoid flattery or excessive praise. Give positive, matter-of-fact reinforcement like, "I notice you combed your hair," rather than, "What a great hairstyle." The latter may be perceived as insincere and can diminish the patient's trust in you. Set limits on time discussing their failures. Accept the patient's negative feelings, but redirect them when needed. Teach assertiveness, which includes saying no when appropriate and setting personal boundaries if this is applicable to the patient's situation. Additional nursing interventions include helping patients identify their strengths, encourage patients to take ownership over goals being set, and encourage small, manageable, attainable goals for their treatment. Explore problem-solving models. You can use example from the patient's situation. An example may be, when you found the toaster was broken, you threw it against the wall. What could you do differently next time? Help the patient to identify supportive resources such as family, friends, community, and religious affiliations. Be sure to keep the care patient-centered. When implementing nursing interventions, avoid being overly cheerful, as this can make patients feel worse because it minimizes the impact of their feelings. This isn't to say you can't smile or express any sort of happiness, but try to adopt a neutral attitude while being confident they will get better. Also, avoid allowing their mood to affect yours. This is called emotional contagion, and it is a real phenomenon. It is important to be empathetic, but keep emotional boundaries for your own mental wellness. There are no tests to diagnose depression, but laboratory tests may reveal an underlying medical cause for symptoms or may be important to monitor because of these medications used to treat depression. I had two instances where a patient presented with depressive symptoms and it was actually a medical disorder. The first patient was a teenager girl and all she reported was a depressed mood. We did some labs and she had Hashimoto's thyroiditis. Once she was seen by a specialist and put on the proper thyroid medication, her depressed mood resolved. The second patient was about 8 years old and had been put on an antidepressant by another provider for fatigue and feeling sad. It wasn't working, and we ran some lab studies and she had type 1 diabetes. So endocrine and thyroid dysfunction can cause depressive symptoms. Electrolytes, urinalysis, toxicology give some information about substance abuse. Liver function tests can be used to monitor some medications used for depression. A pregnancy test is ordered in females who are of reproductive age since antidepressants may affect fetal development. Collaborative interventions include medications, psychotherapy, and non-pharmacological treatments, which I will elaborate on in the next few slides. Lifestyle and complementary activities offer important treatment benefits. Endorphins are effective in elevating mood, making exercise a helpful complementary treatment. Supplements such as St. John's wort, S-adenosyl methionine or SAMe, and vitamin B are often used for depressive symptoms. Acupuncture has been used, and it is suspected that acupuncture helps to raise endorphins. Animal companionship provides meaningful comfort and aids in relieving loneliness and can elevate mood in some individuals. Creativity can assist in healing, and music and art therapy are used to reduce stress. Various medications are available to treat MDD, and these medications are most effective when combined with psychotherapy. I'm going to just give a brief overview since you have a lecture on psychopharmacology as well. Selective serotonin reuptake inhibitors, or SSRIs, are generally first-line treatment. They increase available serotonin, which affects mood and other symptoms of MDD. Serotonin norepinephrine reuptake inhibitors, or SNRI, increase both serotonin and norepinephrine. Tricyclic antidepressants and monoamine oxidase inhibitors are both older classes of antidepressants with significant side effects, so these are used much less than the other antidepressants. On occasion, atypical antipsychotics are used along with SSRIs for severe depression that is not responding to one medication. A treated episode of depression typically lasts about 3 months, and the withdrawal of antidepressants before 3 months almost always results in the return of symptoms. For the first episode of major depression, it is recommended to continue antidepressant medications for 6 months after the patient feels relieved of symptoms. If the patient has risk factors as listed, or it is the second episode of major depression, medications should be continued for 1 year after symptom remission. The risk for depression recurrence increases the more episodes of depression an individual has. After one episode, there is a 60% risk of reoccurrence. After 2 episodes, there is a 70% risk, and after 3 episodes, there is a 90% risk. Educating patients about this risk may help to improve their adherence to the recommended duration of treatment as to lessen the risk of reoccurrence. Similarly to medications being most effective when used with psychotherapy, psychotherapy is most effective when used with medication. Both can relieve depressive symptoms when used independently, but studies continue to show that best outcomes occur with a combination. Cognitive behavior therapy, or CBT, identifies negative thinking patterns and behaviors and helps the patient to replace these negative thought patterns with more positive thinking habits and behaviors. There is also cognitive therapy, which focuses on transforming thoughts to positive thinking, which is also called cognitive modification. Mindfulness is a technique in CBT that encourages conscious living or focusing entirely at the activity at hand. This can help individuals to identify destructive thought patterns in order to change it. Often, negative and destructive thought patterns are automatic, and being constantly distracted can make it difficult to even realize that negative thought patterns are continuously occurring. I also just wanted to mention psychedelic assisted psychotherapy, which is currently being researched, but so far is showing promising results for treatment-resistant MDD. It uses professionally guided use of psychedelic substances and is outside of the traditional psychiatric treatment approaches, but worth mentioning as this treatment is likely to become more common. ECT is used for severe depression in patients who are resistant to other treatments, have accompanying psychosis, and are severely suicidal. It has a response rate in about 80% of individuals, and most have improvement within 3 weeks, which technically is quicker than meds. ECT is a procedure that passes an electric current through the brain in order to induce a seizure, as this changes the brain chemistry. The patient must sign informed consent. It is completed under anesthesia, so the patient is NPO 4 hours prior to the procedure. The patient is given a muscle relaxant, so the seizure activity is often not visible. EEG, EKG, oxygen, vital signs are monitored during the procedure, and vital signs are monitored for several hours following the procedure. Some mild confusion and short-term memory loss, like forgetting what they ate for lunch, is expected following the procedure, but it will resolve. Confusion resolves within an hour, and short-term memory loss resolves within a few weeks to months after treatments finish. As far as nursing care, you want to inform patient of temporary short-term memory loss or confusion, that they will be NPO prior to the procedure, have the patient void prior to the procedure, remove dentures and glasses, and then after the procedure, orient the patient and monitor vital signs. Treatments are usually given 2 to 3 times per week for a total of 12 treatments. Some of you may have had the opportunity to observe this in clinical, but I have a video to show you simulating ECT so you can all have an idea of what the procedure is like. Take a few minutes to read over and select the correct answer from this Kaplan practice question. The correct answer is 2. In addition to selecting the correct answer, think about why the others are incorrect. Is there any reason you would need to turn the patient from side to side? No. Would you need to examine the patient for fractures? No, as they receive a muscle relaxant to minimize seizure activity and that there is no risk for fractures. It wouldn't be wrong to tell the patient that seizure was very short, but what exactly does very short mean? Also, is this the most important nursing action of all the choices? No. Reminding the patient that memory loss is temporary would be more important. TMS is similar to ECT except that it uses a magnetic field that passes through the skull, causing a firing of the cells in the cerebral cortex. It is FDA approved and symptoms improve very quickly compared to medications. Symptoms are improved within 1 to 2 weeks compared to the 6 to 8 weeks that it takes for medications. TMS is as effective for depression without psychosis as ECT, but ECT is best when psychosis is present. Treatment lasts about 40 minutes and are 5 days a week for 4 to 6 weeks and do not require sedation or recovery time like ECT. And it is typically completed on an outpatient basis. The side effect that is most common is a headache, and sometimes there can be a scalp pain and temporary facial twitching. Here is another Kaplan practice question, so take some time to read through and come up with your answer. If you think about suicidal ideation or a suicide attempt as part of the symptomatology of MDD, which answer is most consistent with what you've learned about the other characteristics of patients with MDD? The answer is number 3. Adjustment disorder with depressed mood is another depressive disorder, and it can be referred to as situational depression because the onset is linked with a life event or a specific trigger. Identification of the trigger will be part of the nursing assessment for this disorder, whereas MDD may or may not have a trigger associated with the onset. Symptoms of adjustment disorder usually begin 3 months after an event, but do not last beyond 6 months. We may all feel sad or have a depressed mood after a difficult life event. But for it to be considered an adjustment disorder, the amount of distress is severe enough to cause impairment in functioning. Any life event can create the risk for adjustment disorder, and the risk increases when there is a pre-existing mental health issue, ineffective coping mechanisms, or a lack of support network. There is also risk if an individual experiences several losses within the same time period. The loss may not just be a death, but loss of independence, such as loss of driving privileges in older adults, would be considered a personal loss. Here are common clinical manifestations of adjustment disorder with depressed mood. These are very similar to what's seen with MDD, but less severe and less impactful on the individual's ability to function than with MDD. The patient may not have great insight into their symptoms, but they may be manifesting in other ways in their life. For example, they may be ignoring finances, having trouble at work, having increased arguing and fighting with family members, engaging in reckless behavior or drug use, crying often, sleeping too much, stopping engaging in usual activities. Here is another case study, also about Kate, but a scenario more representative of adjustment disorder. Think about what seems different than the MDD scenario. Also, think about what may be a nursing diagnosis that may be applicable to this situation. Generally speaking, some examples of nursing diagnoses that may be appropriate for a patient with adjustment disorder include helplessness, also powerlessness or hopelessness may be options, disturbed sleep pattern or maybe change in appetite pattern, disrupted family processes, a family contributing to symptoms or family not functioning as a result, situational low self-esteem, or ineffective coping. For Kate in this study, we have assessment data that would support a nursing diagnosis of situational self-esteem, ineffective coping, or hopelessness. Is there any assessment information we don't have in this scenario that you wish you had or would ask about it if you could? We don't have information about safety concerns or suicidal ideation, which is particularly important with these patients. You can see the similarities of nursing diagnosis in adjustment disorder as with MDD, and the plan or goal will be very similar as well. It will be specific to the priority nursing diagnosis and may be related to improving sleep or rest. It may address an individual simply returning to daily routines and functioning. It may address improving self-esteem and of course safety issues and remaining free from injury if applicable. Going back to our scenario, if we were focusing on Kate's hopelessness, how can we help Kate return to a more hopeful attitude? Will we say, "It will be okay, you are only 18, you have a whole life ahead of you"? Instead, we want to say things like, "What have you done well in the past?" Or, "When did you feel successful?" "When have you overcome something painful before?" "When was a time when you had a sense of control in your life?" We want to help patients return to a hopeful attitude by exploring previous achievements, encouraging them to identify strengths and abilities, as well as times when they had control of their lives. Feeling a loss of control can be a common theme, so assisting patients to advocate for themselves will often instill hope and self-esteem. Also, we can identify sources of support since we know this is an important way to promote resilience, and we can encourage family functioning since family is often a source of support. As far as collaborative interventions, they will be similar to MDD in terms of medication, therapy, complementary therapy, and exercise. Often, therapy alone is sufficient for adjustment disorder with depressed mood, and medications aren't necessary. ECT and TMS are appropriate for treatment-resistant MDD, so those are not treatment options for adjustment disorder. The exact pathophysiology for bipolar disorders is unknown, but it is thought to be a combination of factors. We do know there is a genetic component, as children of parents with bipolar disorder have between a 4 to 15% risk of having the disorder, but there are also some home environmental factors contributing to this as well. Mood episodes are often recurrent, with more than 90% of the individuals having future episodes. compared to MDD, where someone may just have a single episode only. And the frequency of mood episodes often increases in frequency as the person ages. The onset is usually between 15 and 13 years of age, so is often a chronic condition. In bipolar disorder, the mood alternates between the extremes of major depression, mania, which is greatly elevated mood, or hypomania, which is slightly elevated mood, and also periods of neutral or euphemic mood. Manic episodes can last from a few weeks to several months. Bipolar disorder is typically a recurrent disorder where more than 90% will have future episodes. Again, compared to MDD, where someone may just have a single episode only. Bipolar 1 disorder consists of one or more manic episodes along with major depressive episodes. The depressive episode presents as we just discussed with MDD. Bipolar 2 has similar criteria except that the manic episode is considered hypomanic or has less of an impact on functioning, which we will discuss in more detail. Mania is described as an abnormal, persistently elevated mood or a euphoric mood that can sometimes involve irritability. There is an increased goal-directed activity or goal-directed energy for most of the day, nearly every day for 1 week, plus 3 or more of the characteristics listed on the slide, such as inflated self-esteem, decreased need for sleep. Some patients will be up for days at a time, more talkative than usual where speech is pressured, flight of ideas. Remember, this is a type of thought process, or they may be describing thoughts as racing, distractible or inattentive, or psychomotor agitation, which is fast movements. Increase involvement in pleasurable activities that have a high potential for painful consequences. Examples are unrestrained buying sprees, sexual indiscretions. With mania, there is a marked disturbance in social and occupational functioning. As mentioned, manic symptoms need to be present for 1 week or necessitate hospitalization, regardless of duration of symptoms at that point. The euphoric mood causes a marked impairment in functioning and may be accompanied by psychotic features such as hallucinations. To compare with hypomania, he is still an mood that is more elevated than normal, but it is less extreme than mania and not severe enough to require hospitalization, and there are not psychotic features. Functioning may or may not be impaired with hypomania, but there is often a change of behaviors that are uncharacteristic for the individual, and people close to the person often notice these changes. So for example, a spouse may notice increased spending or a change in dress or risk-taking behaviors like gambling that seems out of the norm for his or her spouse. Hypomania does not consist of psychotic symptoms such as hallucinations and delusions, and symptoms only need to be present for 4 days in the case of hypomania. Rapid cycling can occur with either bipolar 1 or 2, and this means that during a 12-month period, there are 4 or more episodes of either mania, hypomania, or depression. There are at least 2 months between each episode, if of same nature like depression followed by depression, or there is an immediate shift of mood from depressed to manic or vice versa. In the latter case, the individual can experience episodes more than once a week or even more than once a day. This is more prominent in female patients when the patient is younger at the time of the symptom onset, and when the symptoms do not respond well to treatment. The patient with bipolar disorder will have different needs depending if experiencing major depressive episode versus mania. The nursing process will be similar as previously discussed if the patient is experiencing depression, so I will focus on mania as we move forward discussing the nursing process. During the assessment, the patient may have trouble cooperating, so you may need to get a collateral information from family. Collateral information means you will be asking the family about behaviors, how the patient has been functioning at home and work. During the mental status exam, you will pay attention to thought process. Is it disorganized? Are there racing thoughts? Is there inflated self-esteem or grandiosity? Are there delusions? You will also pay close attention to mood and affect. Behaviors include reduced need for sleep or food, neglecting hygiene. They may be inappropriate with staff or patients. A feature can be increased social or sexual behavior. The patient may be very distractible and may have perceptual alterations like hallucinations. Remember, this is only with BP type 1 or bipolar disorder type 1. So it is important to assess for this. They may have a surprising sense of well-being, enjoying the feeling of euphoria, and be upset or confused that others see it as a problem. Continued features notable on assessment may be rapid, loud, pressured speech. So recall the video from the psychosocial assessment lecture of the woman showing her legs. Flight of ideas, poor judgment and impulsivity. This is often reported by family. Frequent evidence of this is spending money, shopping, drug use, and being overly sexual that is out of character for that individual. The patient may have an unusual physical appearance, either being unkempt since they are neglecting self-care or dressing inappropriately for the season or temperature. Now that you have an overview of bipolar disorder, read over this question from Kaplan and think about your answer. Note that Kaplan uses elation phase to mean mania. The answer is number 4, as impulsivity is a symptom of mania that can lead to poor judgment, in this example, in the form of excessive spending. Nursing diagnosis appropriate for a patient with mania may be risk for injury, disturbed thought process, impaired social interaction, ineffective impulse control, self-care deficit, sleep deprivation, and risk for suicide. The last is particularly important as individuals with bipolar disorder are 15 times more likely to commit suicide than the general population. Safety must always be a consideration if the patient is at risk for self-harming behaviors. If there is a low risk for a patient with bipolar disorder, additional goals may involve the patient remaining focused on a stimulus for more than 10 minutes at a time, or whatever time is appropriate for a patient, the patient being able to make a choice between 2 or more alternatives, the patient having appropriate behaviors on the unit or in social setting, the patient completing various aspects of self-care such as food intake or hygiene, the patient having improved or more restful sleep. As always, the goal will be appropriate for the patient's priority nursing diagnosis. Nursing interventions may focus on encouraging reality-based thinking, and this can only be done by simply sharing your name, date, and time, and by following a schedule for consistency. If delusions or hallucinations present, acknowledge the patient's belief but share your own as well. An example of this is saying, "I understand that you believe that you own this facility, but I have a different understanding." This conveys acceptance without supporting the false belief. You can provide positive reinforcement when the patient is displaying reality-based thinking. Improving socialization will likely be focused on improving how the patient interacts with others, whereas in depression it is likely getting the patient to interact at all. This may require mediating between patient and others if there is a negative behavior. Patients experiencing mania often have interpersonal chaos due to crossing boundaries and testing limits and rules. Setting limits are important in these instances. Staff must agree on limits and enforce consistently, and violations of limits must have consequences. Limits should be enforced matter-of-factly and expectations of behavior made clear to the patient. An example is saying, "If you are disruptive during the group therapy, I will ask you to leave." Promote improved self-care by monitoring intake and output, personal hygiene, and provide assistance when necessary, but allow them to do as much for themselves as possible. Decreasing stimulation can calm the patient's mood and help with rest. Examples of decreasing stimulation are dimming the lights, limiting involvement in lively activities, limiting competitive activities, playing soothing rather than loud upbeat music, to name a few examples. Promoting sleep is important as individuals with mania often sleep very little or not at all, and may still experience energy even when their body is nearing exhaustion. When possible, facilitate a regular sleep-wake cycle and allow for them to have uninterrupted sleep if they are sleeping during the night. Additionally, remain calm, relaxed, with a firm, matter-of-fact demeanor. Having stable role modeling behavior is often reassuring when a patient is not in control of their own behaviors. As always, build a trusting relationship and promote and ensure safety. So how do we do this? We can promote safety by keeping the room simply furnished and by removing smoking and contraband materials. We can also promote safety by completing safety checks, which includes an assessment each shift, assessment for changes in mental status after significant interactions with family or physicians, therapists, as this can be agitating, facility safety features, staff observations, which is one-on-one eye contact every 15-minute checks, which we discuss with MDD. Create structured program with rest periods and limit activities that could become competitive. If there is a concern that the patient may attempt to escape, they may be deemed an elopement risk. You must redirect patients who are at doorways. Do not allow them to be on patio. Prevent mood and behavior escalation when possible by staying calm and minimizing stimulation. The patient with good insight may be able to identify their own triggers and calming strategies, and it is always good to involve patient in their care and decision making when possible. Here is a practice Kaplan question. Go ahead and read it and think of your answer. The correct answer is number 2, as you now have learned that patient experiencing mania often flight of ideas, increased excitement, and is easily stimulated. Here is another practice Kaplan question. Kaplan often uses the word elation for an elevated mood. Take a moment to think it over and come up with your answer. The correct answer is number 2, as patients experiencing mania need an outlet for their increase in energy, making distraction and redirection a frequently used nursing intervention. Next, we will review the collaborative interventions for bipolar disorder. As with depression, diagnostic tests do not diagnose bipolar disorder, but may be ordered to rule out other conditions or to determine if drug use is contributing to the symptoms. Hyperactive and agitated behavior usually responds quickly to medications that stabilize the mood or mood stabilizers. This consists of various classes such as antipsychotic meds, lithium, and anticonvulsant medications. Psychotherapy can also be helpful along with case management and community resources that can assist with optimizing independent functioning. The National Alliance on Mental Illness is a very useful resource and offers patient and family-friendly nature of the information on their site for disorders such as bipolar. As mentioned, bipolar most commonly has recurring symptoms, and it is important to involve both the patient and his or her family to create relapse prevention strategies, to educate them about the illness, the expected course, and the importance of adhering to treatment medications. Medication noncompliance is a frequent issue because most people enjoy feeling euphoric and don't want to take a medication that will diminish that feeling. As nurses, we can also familiarize ourselves with community resources in order to educate patients and families on available services.
That completes the lecture, but please do not hesitate to come by my office or email me if anything was unclear, you have any questions, or if you did not understand the rationale for the correct answer for those practice Kaplan questions. Thank you so much for your attention.